such an extent that perhaps they could easily find this model, if that makes sense. So the 10 things were that this model should provide comprehensive, this is on page 4 and 5 of the re-engrossed bill from last year. Comprehensive benefits for medical care, including dental, hearing, vision, and mental health. Very important. That was number 1. Number 2, and this one, number 2 is a little sticky, I guess I should say. Number 2 is the providing home care and long-term care, at least at the level of coverage currently available to Coloradans who are Medicaid recipients. The reason I bring up that it's sticky is that this particular piece is going to potentially have a huge impact on the overall cost to the system. And so we might have to consider that they model a system with and without this particular piece, just so we can see what we're dealing with. So keep that in mind. Number 3 was making sure that this system will make sure that decisions are in the hands of the patients and their healthcare providers. Just like what I've always say, let's get back to the doctor and the patient, and let's get the middle people out of there. Number 4 is to allow patients to have free choice among the providers that participate in the universal healthcare system. Again, so that patients are in control of who they go to. Number 5 provides healthcare benefits to all Colorado residents. So here's where we're covering, the hundreds of thousands of people that don't have. It's suspected that we have 350,000 people in Colorado that have no health insurance, and that we have approximately 600,000 people that have insurance, but they're so underinsured that they don't get health care because it costs too much. So this system would cover everyone. Number 6, it's funded by premiums based on the individual's ability to pay. So we're all participating at a level that we can. It will, number 7, prohibit deductibles and co-payments. Like, wouldn't that just be magical? Like, this sounds amazing. I know parts of it sounds too good to be true, but we know from their high level study that it's not impossible. We just have to, again, get the details to prove it. Number 8, ensures fair drug and hospital prices, as well as fair payment to providers. This is critical because we need our providers to be attracted to the system. We need providers to know that their very important services are going to be paid for, and that they are supported in their professions. So, and number 9, we would have to set up a publicly administered nonprofit enterprise that kind of administers the healthcare costs as far as paying for them. And number 10, it will be designed to prioritize benefits and access to care for patients while preventing barriers to care that are imposed for the purpose of increasing profits, which we see in the insurance model. Health insurance, its goal is actually not to care for patients. Its goal is to increase their bottom line. And so it's such a backward system, as you all realize, that, from the insurance standpoint, they want to not pay for things, which makes sense for their survival. but it's not helping access to care and getting people the care that they need. So that's the overview of what the model legislation would look like. And so the School of Public Health needs to consider all of those things as they look at this. And then it goes a little further, and we are giving the School of Public Health another list of 13 things that they can consider. And those 13 things are on page 5, 6, and 7. I won't read them all to you right now, but they're listed by lowercase alphabetical letters, A, B, C, D. So there are 13 things that they are allowed to consider. That's why we're using the word may there, because they kind of need some flexibility on how they build their models. But it was important enough for us to put it in the legislation so that they understood the legislative intent of these things are important. Please consider. And so that there are 13 very important things that are listed there. There are even subcategories, as you can see on page 6. We want them to describe how our universal healthcare system will provide the following 8 things. So there's a lot of direction in this bill. I think it's really well laid out so that we're making it really clear what we're talking about and what we want them to do. So it's not a completely open-ended homework assignment. We need this level of detail. I need this level of detail, and so do all the other legislators and anybody advocating for this, because if and when it ever comes to a ballot initiative, we have got to be able to answer all these questions. We have got to be able to educate voters and not be put in a position, well, I don't know, we'll figure it out. We have to know. So there also, we will continue to have in the new piece of legislation, which is going to look a lot like this when it starts, when we start kind of stakeholding it, and then we'll edit. And we will still have the task force that is part of this bill involved, and their job, and the people on that task force, it is created to help be the advisory group to advise the School of Public Health when they need questions are going to come up. Mm-hmm. And they're going to be like, I wonder, blah, blah, blah. So they'll need to be able to go back to a dedicated advisory task force to be able to have guidance from them as they go through their analysis and their study. Currently in the bill as written, there were 10 members on that task force. Most likely through discussion, we're going to be adding to that, because with further thought, we don't want to make the task force and the advisory group too big. 10 is a doable number, but it can also be bigger. So we have some ideas of potentially adding some other voices, other perspectives to that advisory group. So I think that's an important part, so that the state legislature is not just sending this off to the School of Public Health and then just saying, see you in a year and a half, or how 15 months or whatever it's going to be. They'll have this group that can meet up to 6 times throughout this process to be in conversation and contact with the folks at the School of Public Health. So I love that part of the bill. It makes it so that we are still very much in touch and making sure things are on track, all of those parts. So and again, I think the bill from last year, I think it gave them about 15 months to complete the task. And we're already in contact with the School of Public Health about, is that enough time? Can you get it done in less time? We want to make sure that the funding for this study is adequate, that we don't want them cutting corners. Again, our whole intention is to do it right, to be as thorough as possible, to think of all the questions that we possibly can, and to find out if this can work in our state, so that is the overview that I have. I would be glad. Oh, you guys wanted to know what happened last year. So if you want me to keep going, or if you want me to pause.
Oh, no, I'm very curious about that.
Yeah. Aren't we all? So it started in the House last year, and it's going to start in the House again. And I'll tell you why in a minute. It started in the House. So Representative Basenecker and myself were the sponsors, and we got it through committee. We got it through our appropriations side of things. There was a little education that had to happen with some appropriations members that they just didn't really know the bill's purpose. Mm-hmm. And giving them a little more information, because they weren't on the Health and Insurance Committee, so they didn't hear the discussion. Of course, it's hard because there's 600 and something bills that come through. And so it did get through our Appropriations Committee, and then it went over to the Senate. The Senate is a whole different animal. And they're not keeping track of what the House is doing or keeping track of the discussion around the bills. So it got through their committee, and it got hung up in their Appropriations Committee for a while. Again, appropriations members didn't understand the value of obtaining this data, even though we kept saying this is a study bill. This is not a referral to the referendum to referral to the ballot. It's not that. It's a study following on 1176, so that we have a deeper dive into this. Why are you afraid of data? Data only helps drive, better data drives better decisions and better policy. And it's really important for us to have, because people of Colorado are asking for this time and time again. And we finally kind of flipped the script there at the end and said, because they were afraid that, like, this isn't going to happen. This is never going to fly in Colorado. We can't afford this. Why even do the study? So they kind of had this mental block. So Rep. Basenecker and I just decided to say, well, what if the study proves that we can't do it? What if the study proves that we're too small with 6 million people? We're too small. We need a regional approach. What if it proves we can't do it, which is what you're thinking, we can't do it? Like, wouldn't that be great for us to be able to tell the people of Colorado, we can't do it, and here's exactly why? Because now we have all this, nitty gritty details. Yeah. And that's what helped turn some minds, because they kind of already had their mind made up. And we just said, why are you afraid of data? It's going to help us one way or the other. Mm-hmm. Of course, we all kind of know that it's going to help us prove that it will. But, playing the other side, I'm like, okay. Yeah. And then that's when they finally go, oh, yeah, okay. So it got through appropriations, but now we're down to like the last 2 days of session. And literally it was a Saturday, and I think we're supposed to end Monday. And so the bill was supposed to come up on second reading on the Senate, and it's Sunday. And they didn't come in till noon on a
Oh.
Sunday because, you know, they have to sleep in. I don't know, like we were there at 8 o'clock that morning. I'm kind of making fun of the senators
Yeah.
now, but
We won't tell them.
it, so, and they had they had a bunch of things on their docket. And
Mhm.
some of them were really contentious,
Mhm.
if anybody was paying attention that day. So I'm in their galley, and it's 11:30 Sunday night, and they
Oh,
haven't gotten to it. And if they don't get to it before midnight, it's lost that night because they needed a second reading before they could get to a third reading the next day, and it just didn't make it.
it just
And
didn't-
so it was this delay, this not understanding, this preconceived notion that this is stupid, it's not going to work anyway, we can't afford it.
Hmm.
But it was being able to say, let's prove we can't afford it. Like, if you're right, then you shouldn't be afraid of this bill.
Done deal.
And that's what changed. That's what changed people, but we were too late saying, plus there was just inefficiencies all along. So in the meantime, that's what happened basically. We had the votes on the House floor. We knew we had the votes on the Senate floor too. It was wildly popular. It's like one of their top 5 priorities. So this summer, there's been, the work with the Colorado Foundation for Universal Healthcare and all the other advocates have been continually working to talk with their representatives and senators. I had multiple opportunities to talk with the chair of the Senate Appropriations Committee, and he is 110% on board. And he was kind of one of our roadblocks. And so he is all in now, and that's huge. That's a big deal. And he will, and I will be talking with our House Appropriations members too, but we already kind of got them on board last year, but we'll be checking back in. We've checked with the governor's team. I'm going to be certainly sending them a draft when we get it. They love this bill. I'm like, okay. So it seems like things are opening up. People are understanding, and as frustrating as government is, sometimes that's what it takes. It takes a little, like you don't get it through the first time. And it's really frustrating because it just feels like you're kicking the can down the road, and you just have to wait even longer. And I that's very frustrating for me as a veterinarian too, because I like to fix things now, get it done, send the animal home. Let's just, but that's where we're at. This is my pre-file bill. That means it's my number 1. It'll get introduced ASAP. We're going to have it ready to go because we pretty much have it. We're going to be, amending it somewhat, but the School of Public Health is ready to go. So I think we're in a really good position, and I welcome questions. I welcome feedback. Would love your support as well. We're looking for support everywhere we can get it, put on our fact sheet. So what questions do you have?
One quick question. First, Representative, do you have a co-sponsor in the Senate to help?
Oh, yes, we have all the co-sponsors. So it'll
Okay.
be Representative Basnicker and I again, me. And then it's going to be Senator Janice Marchman, along with Senator Jaquez Lewis again. But Senator Marchman is really fired up and ready to go. And I think it's going to be very helpful that there's more than one senator
Mhm.
on the bill this year, because it kind of takes a couple of people to really work the system. And so that's going to be really, really helpful. So yeah, we have all our sponsors. Yeah.
Good, okay. Go ahead.
Yes,
Christine.
I'll have you call on people, not me.
Go ahead.
This is Dr. Christine Embry, and I just had a couple questions. One of them is it the same House bill number?
No, it will get a new number, and
Okay.
it won't get a number until January, until it's introduced. Wait, is that right? Bill paper, yeah. And when it's introduced, it'll get a new number, so it won't have the same number.
And the timeline on it, you mentioned something like 18 months or 15 months. Is that kind of what's
Oh, so
related?
the bill, no, the bill will get introduced in January. It'll get assigned to the Health and Insurance Committee. If we're ready to go and we have amendments or whatever we need, we've got our testifiers lined up, then I can go to the chair of the Health Committee and go, get us on the schedule. Like, let's get this in and out of here. So then it'll go to our appropriations. The reason we're starting it in the House again this year is because of the budget process. We're going to have the budget first this year, whereas the Senate had it last year, and that's a delay in everything. And so because the House has it first, we'll get in and out of the budget. So we'll be done with the budget faster than they are. And that helps us with bills getting through. So then it'll go to the Senate, they'll do their thing, get it through, hopefully, before the very last day. And then it'll go to the governor's desk to be signed. And once it's signed, we'll have the kind of the due date written into the bill when the School of Public Health, first they're going to have to choose the task force members. But this past year, they had till December of, or let's see, they had till October 1st, 2024. So they were going to have about 15 months to get their study done. That's probably what they're going to want again, or they might want just a year. So let's say the bill gets signed in June. They'll have till the following late summer, early fall to get their homework assignment done. Did
So
that
you're
answer
talking
your
like
question,
2025?
Christine?
I think so. I think you said maybe 2025.
Yeah, it would be. It's, because last year's bill was 2024. So we've already kicked it out a year.
Okay. And I promise this is the last question, but it's my most evil one. So I know that there are like reasons why bills don't get passed through Congress because of influence by lobbyists and such. Are there lobbyists against this right now already? Or was there last year? Was that part of the component of why it didn't get passed through quickly? Were there lobbyists behind the
No,
scenes to oppose it?
There was not a big presence of lobbying resistance to this. It was more people not thinking it was worth it. So no, we had Virginia, do you remember? Like, I don't remember a whole bunch of
Yes, there were a
negative.
few,
Who were they?
expected. Well, one was actually the manager of a trust fund for a union company.
Oh, yeah,
so
but he was just a loudmouth. That wasn't really,
Well,
yeah.
there
Okay.
were a few folks who were
Yeah.
against it, but it was the usual suspects that you would expect.
But
it wasn't
wasn't
huge.
Yeah, and they didn't have much influence. So that's why I'm
Right.
like, yeah.
I mean, I think
I
because it's
thought
a
they were pretty
study.
weak.
Probably, yeah, because it's a
It was
study.
pretty, it's
yeah.
a study. We just kept saying it's a study.
Because, honestly, just to bring a light on it, I think the University of Colorado benefits greatly from our dysfunctional healthcare system. And I think that they're going to be, not too interested down the road in continuing to tell us that it works to change it. I just wonder about that influence. So I have this other perspective of like how much influence would be against us going forward on this in our own state, but maybe that's more of a national issue, not a state issue.
Well, yes, and to ever change this, it's going to take a vote of the people of Colorado. And
Mhm.
so that will be, if it comes to that, the huge, expensive education push to the voters, because there'll be big money fighting against it. So that'll be the battle.
Yeah, okay.
This bill is not the battle. The battle will be, yeah, that's a good question.
Mary,
Yeah, am I unmuted? Can you hear me?
you can.
Yeah, we can hear you.
Okay. I wondered last year, and I continue to wonder, why the constraint for publicly funded but private delivery? We know that a lot of the costs in healthcare are due to that private delivery model that we have. And the prices keep going up and the administrators make thousands of dollars. So I'm wondering why the constraint on the private delivery public finance?
So this is a rhetorical question? Well,
but somebody had to decide in this bill that you wanted to do publicly funded but private delivered. Why was that decision made?
I
answer that?
guess I don't really understand what you're asking. Virginia's raising her hand.
I think I understand what you're saying. What this is
Okay, I don't.
basically a different way to say single payer.
Mhm.
Is that instead of, all of the premiums that we pay into insurance companies would be paid into this payment authority, which would be the nonprofit enterprise that Karen talked about. And then it would be used to pay directly to the healthcare providers
The
without the
providers, yeah.
without the middlemen of the insurance companies getting their fingers in there with, all their administrative roadblocks, which are basically just, skimming money out of the healthcare system. They add no value. And so does that
And
answer
they
your
don't want
question?
to, and they don't want to pay for the healthcare that was given. So, yeah, Mary, is that what
I
you
do
were getting
understand,
at?
but why not publicly delivered as well?
Because that's the
Right,
fight
you
with
know,
the
healthcare
Medicare for
publicly
all.
funded.
That's the Medicare for all fight that we have to
Right.
battle upstream, is that when you start to talk about demanding, dictating different care and like the Medicare for all system, I mean, they're very different. Private and publicly administered are very different, I think.
Well,
think
because
really
we
resist-
we don't have doctors and healthcare providers that work for the government. They are private entities. And so we want to be able to go to our doctor's office. We want to be able to go to my dentist down the street. So they're not publicly owned healthcare or so that's why it's privately delivered, because it's all of those healthcare providers, those doctors and PAs and nurse practitioners and all those folks is who needs to be paid directly and to get what they're owed so that they are supported. And we're not going through the insurance company that's deciding, oh, I'm only going to pay 60% of what you billed.
Mhm.
Yeah.
Jean?
Okay, thank you.
Jean's next, and then we'll go to Barb.
I think the question that Mary was asking might be responded to a little bit differently. I think you were asking, what is the resistance to this publicly funded, privately delivered proposal? Since it's all obvious to most of us, if not all of us on this call, why we think it makes a lot of sense. And I would answer your question by saying that we know that there is some resistance to the concept of a publicly funded kind of proposal, because people don't always trust the government to run things correctly. And so there's some fear that that will not be well done if the government is in charge. I disagree with that position, but I think that's one of the answers to your question about resistance. A second one is that we know through some very recent polling that the majority of Coloradans believe everyone should have access to affordable comprehensive health care, but they want to keep their private commercial health insurance because they like it and want everyone else to also have coverage by various sources, including Medicaid, VA, Indian Health Services, public options. So one of our challenges as advocates is to be able to persuade the majority of Coloradans that the only way to pay for a comprehensive healthcare plan that would cover everyone in the state is through a one-payer, publicly funded, government-run plan. And that's the challenge, I think, that we have to address in addition to this legislation that needs to be passed. We need to organize ourselves through a major public information campaign to help the public understand that there is only one way to pay for this.
Right. And, you know, as you were talking, you also hear the people look at and hear stories of other countries where they feel like there are barriers to some of the care that is needed, and waits and delays in care. And that's another fear that, you know, those that are fortunate enough to be able to get care when they want it and need it, might feel that they will lose that position of privilege, I guess. And now, since I can't get my knee replaced next month, I have to wait till January. There are those fears as well, because it is fear of the unknown. And when you know something and you happen to like what you have, it's hard to venture into that unknown that might put you as an individual in a harder situation. So
Barb, you're on mute still.
Yeah, thank you for having me. I have a good friend, Kate Shaw, maybe some of you may know. So that's why I'm joined today. But I wanted to just touch on a few items. One was, you know, we have these 30 and 40-year-olds, and just looking at the demographics on the phone, you know, how do we reach them to see why this is important and what they're getting out of it? What's the benefit of them voting on something like this? I mean, we all see it, but, you know, how do we message that to that group that, you know, can go either way? We have a huge population in Colorado that's not affiliated with any particular party. They're in the middle there. So how do we message this, that this is going to benefit you and everyone else long term? And then,
yeah,
you know, we are a country, we think more of individualistic values more so than a community. And, you know, everyone thinks, well, I paid, I worked, I did mine. Why do I have to pay for someone else? And so how do we message that as well? This is really the benefit for everyone, and it really costs us all less to do this. It
And the line.
really is, and,
Right.
you know,
Yeah.
and so I don't know how we message those things. I think we need to focus on how do we message that, because that's going to be critical once it gets on a ballot
Yeah.
for folks to vote on.
Well, and that's why we're very hopeful that this detailed analysis, where as many questions as we can possibly think of, will be looked at and modeled so that we will have those answers that we can turn into succinct talking points to be able to show that even though you as a 30-year-old pay your or half of your premium, whatever, look at how much you're spending per year on your own premiums and co-pays and dental care and your glasses and all of the things that you are paying for as let's say a healthy individual, to be able to show them that you'll actually probably pay less, because you right now you are supporting already all the people that are not paying into the system because we have to, but we're doing it in a very expensive way through emergency room visits, through people that aren't getting preventative care, that, you know, they have chronic health issues that turn into really expensive ways to treat them because we didn't get them early. We're all paying so much more than we have to. And so to be able to bring it down to that individual level, and that's what they're going to be tasked to do, is to say, you know, you're spending this much money for your, you know, nuclear family. And we can show you that you're actually going to spend less and get probably even better care because you're going to have more freedom. So you're right, Barb. We will need extremely good messaging, because the other side is going to have pretty hard messaging. That is down the road, but that's why we need this information, is so that the messaging that we can potentially come up with will be based on actual data that we can show, and to be able to show them that this is going to help you as an individual, and it's going to make a lot more sense for the entire system.
Yeah, and just, you know, the last thing too is if we look at the population of Colorado, 5-6 million, we have about a 1.2 million that are already on Medicaid. We've got probably another 800,000 that are on Medicare. We've got CHIP, we've got VA. By the time you add all those people up, you're almost at 50% of who we have. 40% of all babies are born under Medicaid. We actually are almost there already. And what we're asking for is not a big gap, a big step forward, given the current amount of folks that are already getting public assistance in terms of healthcare. I think people think it's much greater than what it is, but as soon as you tell people, oh, 40-some% of all babies in Colorado are on Medicaid, they're just like, are you serious? 1.2 million people are on Medicaid? I mean, they're just astounded. And so we're already there. This is not as big a step forward as people really think. They just don't know the current numbers.
Yeah, look at you with your messaging. We'll put you in charge.
There you go. Virginia?
I just wanted to say that I do a lot of tabling and so forth, talking about Medicare for all and so forth at the state or national level. And young people are so open to this idea. I mean, they are all over it. Mm-hmm. They understand. And look at the young people who followed Bernie Sanders, and that was his signature issue. And they will. Mm-hmm. I think they're going to be our easy sell. It's other folks. Mm-hmm. Plus, young people many young people can't get a job that has benefits. They don't, many young people are going naked. They have nothing.
Yeah, they're
Because,
just taking a chance. Yep.
yeah, and it's partly because it's so complicated to get health insurance, and then the premiums are so high, and unless you're on Medicaid, that sort of thing. But it's just so complex, and young people get it. You know, we should have Medicare for all. I mean, they've been listening to Bernie for years, and so I don't think that's going to be a tough sell to young people.
And in a way, I think maybe that's where the league can help. I mean, Representative, we are an advocacy organization on certain issues. This is an issue that this particular task force is very interested in. So for us to join forces with, you know, other organizations that are also pushing for this kind of change would help the messaging, help pass the legislation, help with what the next step in implementation is if we get that far. And the league's very good at messaging and working with other groups. So remember that I think we are pretty key stakeholders in this effort.
Yes, absolutely. And I so appreciate that. And you really are good at messaging. And I remember when Senator Foote was working on God, I just went blank. The national electoral vote.
Oh,
What's it called?
National popular vote.
your vote?
Thank you. I like my brain. The national popular vote, and the league was going around and having small group educational outreach and I went to a couple of them, were fantastic. So I know you're good at it and really appreciate that. And also so well respected nationwide for your perspectives and where you come from, as far as being as nonpartisan as possible. So I so appreciate that and your interest and support in this. So we will keep you absolutely posted and in the
Just
loop.
let us know what we can do. I think
Thank
quite a few
you.
of us would be ready to jump in and help.
Excellent. Really
I had
appreciate that.
I had one small question. As far as the funding for the study goes, do you have any figures is
Yeah.
it a scary number? Is it a
No.
number big enough that the General Assembly would say, oh, no, we can't afford that?
Yeah, and that's we got that clear last year that the number was not scary. So the
Okay.
number last year was $306,000. And so it was about 277,000 went to the School of Public Health. There was some cost for the Department of Healthcare Policy and Financing, a little bit here, and then there was some per diems for some of the members that were on the task force. So the appropriations committees on both sides said it wasn't the number that caused any of the hiccups or the slowdown. It was some of the folks just thinking that it wasn't, why do this? So, and we've gotten through that as far as the people that we knew about last year. We've gotten through, there's new people there this year. So that we're gonna have to talk to every individual legislator again and make sure that they understand what it is and understand its value.
Sure. Okay, great. Does anyone have any further comments or questions?
I do.
Okay, go for it.
I've found over the years that healthcare in each individual case is a reflection of your own personal experiences. For instance, I took my grandmother to the doctor and it was a lousy experience. So I hate that one particular hospital. And so individually, we all have our own collective experiences that shape our idea of what healthcare should be.
Mm.
Well, on the provider side of medicine, I've worked both as a corporate provider and a private physician. And in each case, you also have your own opinions as to what that should be. I've worked in rural hospitals where our profit margin was less than 1.5%. And I know of profit margins on the Eastern Slope, which are greater than 20%. So each of those individuals, the personal opinion, the provider opinion, and the corporate opinion, all have a different focus on what medicine is. And so I think, moving forward, and I know this is a study that looks at the appropriateness of universal health care, but for instance, with individuals, it could be a wonderful thing. For individual private providers, it could be very scary. And for corporate medicine, it's very, very scary because of the potential threats to that. So I think that the ability to create a unified understanding or focus or vision of what healthcare is a huge undertaking, but is the key, to finding that acceptance. It's there, it can be done. Universal healthcare would be wonderful, but it's going to take a lot of work.
Communication
Yeah.
wise,
Mhm.
especially.
Thank you for that comment. Yeah, it's not simple, and I have no, I know it's not going to be easy. Getting this bill through, hopefully will go better than it did last year, but the steps after that are not going to be easy.
Mhm.
But the people of Colorado are asking for this, so
Right.
we're here to serve. So
Oh, I love that. Thank you for remembering that.
Well put.
hey, I've been in a service profession my entire life, so
Same.
yeah.
Yeah. Jean, you have your hand up. You're on mute. You're on mute.
Representative, you posed a question that I thought was one of the best ways to help us understand why this analysis bill would be important. And you phrased it in a way that I think is really good for the general public to understand. The question you asked was, is a publicly funded, privately delivered universal health care plan doable in Colorado? I think that language might be useful for all of us when we're trying to explain why this analysis bill is important, is that it's in an effort to answer that question.
Thank you. And that's exactly right, is we're all, people are all coming with some assumption that it is, or they're coming with the assumption that it isn't. I kind of want to know, is it or isn't it? And then what would it look like? And so, and again, it got to a point of frustration in the General Assembly that caused Andy and I to just go, what if you're right and it's not going to work? Don't you want to know? So I'm just sharing that with you all because that's what turned it around. I mean, it was just that simple. Like, you could be right. Let's prove it.
Mhm. I love that. Any more questions or comments for Representative McCormick? Otherwise, we'll let her go. And I just have a couple of announcements and then we'll close for the evening. Anything
right,
else?
well,
Anybody?
Thank you all.
Thank you.
Thank you.
Thank
It's been
you.
a
Thank
wonderful,
you.
Okay, I'm sure
Thank
I'll
you.
see you again. Take
really
care.
detailed
Thank you.
presentation. I appreciate
Okay, you bet.
your efforts. And we'll be in touch.
Okay, see ya.
Thank you. All right, for the rest of us, Pretty good, right? Really informative. I just wanted to mention a couple of things for our November meeting. We're working on getting someone from the Colorado for Universal Healthcare Coalition who's working on this same bill. And they have a two-part goal. One is to get this study bill passed, and then if that's successful, to help with implementation. So we'll have someone at our November meeting from them. And then also, I just got an email from the Colorado Consumer Health Institute. They've got a survey, and I'm going to send it to everybody in this group. They want as many answers as possible on how to improve healthcare access. And I would assume this group would be interested in taking that survey and offering your input. Also, I'll probably send an email following this. So, because I don't know everybody that's here tonight, so I'm going to ask for a little more information about who you are, why you're interested in this subject. Everyone who spoke was extremely well versed in the healthcare arena, so I would like to know more about your expertise so I can call on you later. Anybody have anything else to say?
Thank you
No?
for having this forum.
Yeah, you're
Yes, thank you.
welcome. Sure, our pleasure, and
Thank you.
we'll see you next month.
Okay.
Okay,
All right, take care.
thank you. Bye. Bye.
Talk to y'all. You'll be hearing from me.
Thank you.
Thanks.